Television Network and the Department of Medicine, Emory University School of Medicine present Clinical Conference in Cardiology.
I'd like to welcome you to Cardiology Conference. It's a real pleasure as well as an honor to have Dr. William Roberts return to Atlanta and to Emory. And I think it's fair to say that Dr. Roberts is one of Emory's more distinguished alumni. He's had a remarkably productive and successful career, and Dr. Roberts is an Atlanta native. Escaped Atlanta to go to SMU, I believe, to college, came back to Emory Medical School, trained in Boston and several other places, and since 1976 has been chief of the pathology branch at the what is now the National Heart, Lung, and Blood Institute, and has made enormous contributions to the understanding of coronary artery disease and cardiac disease in general. And we're really honored, and it's a pleasure to have him here. And he's going to speak now on sudden cardiac death, and will speak at 6 o'clock this afternoon at in the Emory Clinic auditorium on cholesterol. I've forgotten the exact title, but would welcome all of you here and in the viewing audience to come at that time. Welcome, Bill.
Well, thank you very much, Dr. Alexander. It's a pleasure to be here. Dr. Shallant, I appreciate very much the invitation. And it's obviously a pleasure to be in Atlanta and be here at Emory. This is where I grew up. Go ahead with the first slide. This presentation has to do with sudden cardiac death. And my only point here really is to show the complexity of this subject. Now, I think when most of us pick up articles on sudden cardiac death, we think that these are patients who died suddenly from coronary disease. But to my surprise, in the last 20 plus years, I've learned that this is not a single cause situation, and it turns out to be relatively complex. Now, what is sudden, for example? Well, sudden is how you define it. Some people define that as instantaneous. Other people as less than 5 minutes. Others as less than 10 minutes. Others as less than an hour. The World Health Organization, a pretty renowned body, defines sudden as a change in clinical status in the last 24 hours, in the previous 24 hours. Now, if one uses the World Health Organization, which many investigators around the world use that definition, one incorporates in sudden death a large number of patients with acute myocardial infarction. Does sudden death have to be witnessed versus non-witnessed? So this can be a complex subject, and it's very important to focus on definitions when one is investigating this topic. Now, this is the way I look at sudden death, rightly or wrongly, that there are cardiac causes, there are probable cardiac causes, and occasionally one is not sure, and then there are clearly some non-cardiac causes. Now, of the cardiac causes, coronary, of course, is by far the most common. But of the coronary causes, atherosclerotic disease is only one of them. Now, usually that's without acute myocardial infarction, but on occasion, a patient, I remember a man waiting for an elevator. This was at NIH. This person had been completely asymptomatic. He suddenly collapsed there and died. And lo and behold, he had a myocardial infarction, about 3 or 4 days old, and he ruptured his left ventricular free wall. So his acute presentation of myocardial infarction was the complication of the infarction, namely rupture. Now, should that be included in a sudden death group? Well, it was sudden, but usually patients with acute myocardial infarction are not included in that. I mention that for the complexity of it. What's the mode of death after bypass operation? In my experience, most commonly it's sudden, just like with native coronary disease. post-resuscitation, and so on. But there are a number of non-atherosclerotic but coronary causes of sudden death. Isolated dissection of a coronary artery without dissection of an aorta, embolism on rare occasion, coronary anomalies, at least in my experience, are quite common, particularly in the younger people who die suddenly. Now, of the non-coronary causes, of course, valvular disease is way up there. Usually it's obstructive lesions, not purely regurgitant lesions. The exception there, I guess, is the patient with infective endocarditis and the patient with floppy mitral valve. Now, cardiomyopathy obviously is a cause of sudden death. Idiopathic types are the most common. I always have a problem in putting people in the sudden death category when they die suddenly, but they have had pre-existing chronic congestive heart failure for a long period of time. Now, at least 25% of the patients with idiopathic dilated cardiomyopathy die suddenly, but virtually all of them have had pre-existing failure. There's no question that hypertrophic cardiomyopathy, the most common mode of death, is sudden. Now, of the secondary causes, the sarcoid, amyloid, myocarditis, neoplasm, we've seen neoplasm present as sudden death. Congenital heart disease, relatively uncommon cause of sudden death, but it can be on a rare occasion, of course. Of the non-cardiac causes, they can be vascular and be non-vascular. Of the vascular causes, dissection, I presume, is probably the most common, although usually it's not sudden death. Embolism, obviously on occasion, rupture of other types, etc. Now, the first group of people I'm going to talk about are those with sudden coronary death due to atherosclerotic coronary disease. Now, most of this data was collected by a former colleague of mine, and what was included here were a group of 70 patients. And this shows the breakdown. Now, all of these individuals died suddenly, usually within an hour, all within 6 hours from previous symptomatic status. Sudden death is usually in relatively young people. For an 80-year-old, an 85-year-old to die suddenly from atherosclerotic disease, relatively uncommon. They tend to have infarction or chronic congestive failure, whereas a younger person dying from coronary disease, most likely to be sudden. You can see how common it is in the men compared to women. Now, we divided these, this was Dr. Carol Warrens who was working with me at the time. We divided these patients into two groups. According to whether or not they had previous clinical evidence of acute myocardial infarction or angina. In other words, was sudden death the initial manifestation of their coronary disease, and that was true in 56% of the 70 patients, or had they had pre-existing angina pectoris and or acute myocardial infarction which had healed. And we asked the simple question here, if we divided them into the two groups, sudden death is the initial manifestation of coronary disease and sudden death a second or third manifestation. And if one looked at the usual way of looking at coronary arteries angiographically, 1, 2, 3, 4 vessel disease approach, which group had the worst, had the most coronary arteries severely narrowed, severely being defined as greater than 75% in cross-sectional area? And these numbers are roughly the same. The one difference was that left main frequency was higher in those who had had pre-existing evidence of myocardial ischemia compared to those who had not. Now, this study basically asks the same question, but angina pectoris, you know, is always a soft data point. You either have, as Sam Levine apparently used to say, you either have angina or you're a liar. It doesn't hold up in court, in other words, but a myocardial infarct is a morphologic thing which is a hard endpoint. And so we divided these groups this way, forgetting about angina, And again, 56% of them had no evidence, had perfectly normal myocardium. At least it was devoid of scars and necrosis, and 44% did. In this group, those with pre-existing scars, they had a higher frequency of three-vessel disease compared to this group. Now, if one wants to really find out how much coronary disease is present, asking the simple question, how many of these arteries are severely narrowed at some point? It's very difficult to show any difference between the various subsets of coronary patients. So for about 10 years, we've taken these arteries off the heart intact and divided them into little bitty 5-millimeter segments and asked how many of those segments are virtually occluded, how many are narrowed to this extent. These are all cross-sectional area reduction, not diameter reduction. And it turns out that in these sudden death patients, that 27% of the little bitty segments were narrowed over 75%. Now, if we eliminated the patients in the third decade of life, that is the ones from 21 to 30 years of age, all of these, virtually all of these patients had over 30% of the 5-millimeter segments narrowed over 75%. Now, we found that 30% or a third of the coronary tree is a very important landmark, really. It's very unusual for a patient to die from atherosclerotic coronary disease unless a third of the links of these arteries are narrowed over 75% in cross-sectional area. So this is a very diffuse process. In other words, there are lesions everywhere. There are severe narrowings in just focal places, but a very extensive process. Now this slide looks by this quantitative approach the same way as the 1, 2, 3, 4 vessel disease approach. These are patients over here in this column that had healed infarcts, healed myocardial infarcts. In this column, they didn't. And what we're adding up here are the little bitty 5-millimeter segments of coronary artery, 1,900 here, 1,500 here. And this shows what you might expect, is those with scars had a little more narrowing. This was 32% of the segments severely narrowed versus 24% here. So previous ischemia tends to lead to more narrowing. This is the group with angina pectoris and or healed myocardial infarction clinically, and again the group with pre-existing myocardial ischemia had as a group more severe narrowing than the other group. There have been a lot of discussion in a number of papers in recent years regarding acute lesions in patients with unstable angina and in sudden coronary death. Well, among these 70 patients, we found 13 who had a thrombus in a coronary artery. And most of these thrombi were non-occlusive, virtually all. And they were quite different in composition from the thrombus in the typical patient with acute myocardial infarction. Now, what the P stands for is platelets, fibrin, erythrocytes, leukocytes. And what you can see from this is among these patients, the dominant component of the thrombi which occurred in them were platelets. Whereas in patients, at least at necropsy, with fatal acute myocardial infarction, the dominant component by far, at least in the necropsy group, is fibrin. So this looks like an earlier, much earlier thrombus. But those thrombi were very small, very short, and non-occlusive. And almost surely, if we had not used this 5-millimeter segment approach, we wouldn't have found them. Now this slide asks the simple question that if we take a group of patients who died suddenly from atherosclerotic and coronary disease and divide them into 4 different decades, this is actually patients 31 to 40, 41 to 50, 51 to 60, and 61 to 70. let's say, is a patient age 31 who dies suddenly, does that person have more coronary narrowing or less than the patient who is 70 who dies suddenly? And the answer to that, there was no difference. If we look just at this portion up here, these are the percent of 5 mm segments of coronary artery that are severely narrowed over 75%, those two groups. And what this shows is whether you died young or whether you died much older, the amount of narrowing in the coronary tree was similar. Now I'm switching gears to some random groups of patients who died suddenly. Now this is a study we put together a few years ago. It included 6 patients who died suddenly while running. Now these were conditioned runners, and the definition for inclusion in this study was that they had to have run 1 year or more, and this is how many miles they ran a week, anywhere from 14 to nearly 110 miles a week. And all of these patients were asymptomatic, that is, they had no evidence of myocardial ischemia when they became conditioned runners, and all of them died suddenly. Now this particular patient right here was a congressman from Maryland. His wife does not mind my mentioning that. But he ran about 20 miles a day, and his last year of life he started getting chest pain during his first mile. And then he would slow down or stop, and the pain would go away, and then he would continue his 20-mile run. And one day he had collapsed during one of those runs. Let me just mention here, look at these total cholesterol levels in these patients. I mean, these are very, very, very high levels. This is what was seen at necropsy. Now this was a child here who had a congenital anomaly. I shouldn't even put him here, but we did quantitation studies on 3 of these patients, and 50%, 56%, and 34% of the entire lengths of the coronary arteries were narrowed greater than 75% in cross-sectional area by atherosclerotic plaque. So here's a group of people who are real runners. Now this person was in several marathon runs. This person was in a couple of super marathon, I guess this person completed 6 42-kilometer or 26-mile runs and 7 80-kilometer runs. Now if you stop at McDonald's on the way home from a 20-mile run, that run is relatively neutralized from a health standpoint. Now some of you might have been watching television of the Detroit Lions back in the 70s when Charlie Hughes, a flanker back, who had just run out for a pass, was walking back to the huddle, and he suddenly collapsed and died. Well, this is the heart of Charlie Hughes. This man, about 6 weeks before he died, developed chest pain after one of the Sunday National Football League games. And the orthopedic surgeon, who was a team physician, thought he may have a ruptured spleen. They put him in the hospital and did an aortogram, and it was all right. And they sent him home. Then he had the recurrent pain again. About 3 days later, they brought him back in the hospital, and the pain disappeared in a couple of days, so he went home again. And he played in the Sunday game each of the next 6 weeks. But when he died, he had a myocardial infarct, which was relatively large, posterior wall of his heart, which looked about 6 weeks of age. But it's interesting that his coronary arteries were terribly narrowed, and there was a great deal of hemorrhage into his atherosclerotic plaques, particularly left anterior descending. In other words, if you're tackling and blocking and have normal, pliable, flexible coronary arteries, that probably causes no trouble. But if your coronary arteries are terribly atherosclerotic and you're banged on the chest, it can be a problem. And this is one of his left anterior descending segments, just loaded with hemorrhage into a plaque. Now I show this because this is Charlie Hughes right here. He was 28 years old at death, and when he became a Detroit Lion back at age 22, 6 years earlier, he was found that his total cholesterol level was about 410, and that a number of his family members had hypercholesterolemia, but that was forgotten about during his next 6 years. Now this is a diagram of a heart of the Auburn fullback who died about 3 or 4 years ago during spring sprints. And his heart was sent to us, and in initially looking at it, I didn't see anything wrong. And then I felt some bump here over the ramus branch, which arose between the left anterior descending and left circumflex. And then we sectioned the whole segment of that bump, and lo and behold, it was an intersusception of one portion of the coronary artery protruding into another. Now, I'm not sure this was the cause of death in this particular individual, but that's the only thing we saw in the whole heart. And when that occurs during wind sprints, maybe that's enough. Now, this is a coronary artery, the true lumen of which has suddenly been squeezed by a dissection in the outer media. There's still a rim of media, or at least particles of media out here. This was a young lady, 23 years of age, always healthy, was running for a bus one morning, suddenly collapsed. And lo and behold, she has a dissection of the left anterior descending coronary artery and also a portion of the left circumflex. No dissection of the aorta. In other words, this is isolated dissection of a coronary artery. This is an entity, of course, which is rare, but it seems to occur in women and in young women. The reasons for this, I'm not sure. Now, this is some data in 3 patients we've studied who during life had documented evidence of coronary spasm, of Prince-Metal's angina. And the question has arisen through the years, does spasm kill? Can an artery clamp down enough by spasm alone to cause fatal myocardial ischemia? Well, this is my entire experience with that particular question. These are 3 patients. All of them had documented spasm by coronary angiograms. This 32-year-old lady here had fixed narrowing of no more than 25% diameter reduction in 2 arteries, and that was 78 days before she died. But with spasm, that narrowing went up to 90%. At necropsy, 78 days later, the amount of fixed narrowing in those arteries was quite severe, quite severe. This 57-year-old man had virtually clean coronary arteries, minimal fixed narrowing with spasm, went up to 90%. Now, that angiogram was about nearly 3 years before death, but look at the amount of narrowing in that artery at necropsy. This patient, interval from the last cath was only 30 days, fixed narrowing up to 50%, spasm up to 100%. At necropsy, there was severe fixed narrowing. The point of this is, at least in my experience, I've not seen spasm by itself in the absence of fixed narrowing sufficient to kill. It may cause chest pain. I'm not convinced it causes myocardial necrosis either. Now, this is the left anterior descending coronary artery in this 32-year-old lady here who had coronary angiogram 78 days earlier. This is the first 5-millimeter segment of the left anterior descending. It looks good. Now we have a little plaque. This is 1.5 cm. Now we're getting more plaque. And here at 5 or 2.5 centimeters downstream, that artery is pretty narrowed by fixed plaque at that point. And here we have some more down here. In other words, maybe spasm by itself cannot be fatal. The next 2 slides are some stories of patients whose hearts I studied. This man, a 47-year-old taxi driver, was well until about an hour before death, when he became enraged, keyword, enraged, because his taxi was bombarded by snowballs thrown by 3 youths. One snowball entered an open window and hit him in the face, knocking off his glasses. He immediately radioed the police, who arrived several minutes later and apprehended the youths. The police described the taxi driver as livid with rage over the incident and advised him to leave the scene. 30 minutes later, he radioed his dispatcher that he was having breathing difficulties. He arrived at the dispatcher's office a few minutes later and collapsed and could not be resuscitated. Now, here's a situation that this fellow has 3 coronary arteries severely narrowed by atherosclerotic plaque. His myocardium was normal and the heart was of normal weight. But this is a psychic event, major stress for him, enraged, that brought on this sudden stoppage of his heart superimposed on severe coronary narrowing. Now here's a story of another man, a 60-year-old man, school teacher, had been well all his life except for recognized systemic hypertension until a few minutes before death, when he became enraged when trying to prevent 2 students in his gym class from fighting. He finally broke up the fight, and while walking away from the event minutes later, collapsed and died. Necropsy in him showed the lumens of the major coronary arteries to be free of significant luminal narrowing, but the heart was enlarged. The myocardium was free of necrosis and fibrosis. So 2 sudden deaths. Both of those individuals had a stressful event. They became enraged. Now, I don't think a stressful event superimposed on a normal heart causes sudden death. I've never encountered that. On the other hand, if you have a stressful event and narrowed coronary arteries, even though the heart size is normal, there's no question, as shown by the first of those 2 cases, that this can occur. The second patient was hypertensive. He had normal coronary arteries but a big heart, and there's a good bit of evidence that this event can occur in people with left ventricular hypertrophy, and that's one of the dangers of hypertension. Now, I've always been intrigued by George Ingalls' article published in 1971, and what he did here was collect newspapers from around the country and read the obituary page, and people who died suddenly, he tried to find out the acute life-setting events that precipitated their sudden cardiac arrest. And usually, he was able to come up with something that was superimposed, I presume, on their very narrowed coronary arteries. Now, how this works physiologically or pathogenetically, I don't know. This has been speculated by some people, particularly the people that produce propranolol, for example, because it diminishes this a bit. Now, what do you see there? Well, I think this is a very prolonged QT interval, and we've studied several of these patients now, and as far as I can tell, their heart is entirely normal. One of them, I believe, 2 years ago was a boy, 14 years of age, who was over at his girlfriend's house, and he suddenly collapsed and died. He was taken to the hospital. They called his mother from the hospital. His mother came rushing in. His younger brother heard his mother say, "Oh my goodness," run to the hospital, and then when she came home from the hospital, the younger brother ran out to the car to see her mother, and when he apparently saw her face, he too collapsed and died right there on the spot. So both brothers, sudden death within a 90-minute period. Now, we think it was this situation here of a prolonged QT interval precipitating ventricular tachycardia. But the heart, as best I can tell in that circumstance, appears normal. Now, this is some data we collected. I say we, primarily Jeffrey Isner, when he spent 2 years with me. We collected actually from the CDC here in Atlanta, working with them, these patients who had the low-protein modified fast diet. And as you know, that was the rage 10 or so years ago, and it was very effective. But lo and behold, some of those patients died suddenly. And these are the 17 whose hearts we studied. Mainly women, young, And these were the superstars of their particular diet clinic. And what I mean by that is they really lost a lot of weight in a hurry. Look at this, percent body weight lost averaged 35% in a 5-month period. So a tremendous loss. Now all of these patients had, those that had electrocardiograms, all had prolonged QT intervals and all had documented ventricular tachycardia. Low voltage was present in most of them. So it looks like a lot of weight loss over a very short period of time can be associated with prolongation of the QT interval. This is normal here. All of these patients had prolonged QT interval. And if you do have somebody who's losing a lot of weight in a hurry, you better do some electrocardiograms on them. Now, coronary anomalies. I don't believe I saw a fatal coronary anomaly until about 1972. But since that time, I think I've sort of been tuned into them. And it turns out that they're a pretty common phenomenon. Now, these are the various types of coronary anomalies that have been associated with sudden death. Now, the most common, by far, is this situation. And that is the origin of the right coronary artery here from the left sinus of Valsalva, or origin of the left main coronary artery from the right sinus of Valsalva. Now this is the one that is most commonly associated with sudden death. The typical symptoms, particularly in these patients, are fainting with exercise. Usually the person is a young boy, 14 or 15 years of age, is out on the soccer field, so on, is running, and suddenly collapse. So this is a very dangerous lesion. And it seems to me that the proper therapy, once this diagnosis is made, is a bypass operation, because sudden death is extremely common in this group. We've studied now about 12 of these patients, and I believe 10 of them died suddenly. Now this entity here is far more common. It's at least 3 times as common as this one, and fortunately most of these are benign. But there are exceptions to that. We saw 2 hearts this week that looked exactly like this. That is, the right from the left sinus and the right coronary artery was dominant. It's non-dangerous if the right coronary artery is non-dominant. Likewise, this one is probably not dangerous if the left circumflex is non-dominant. I'm not positive about that, but it looks that might be the case. Unfortunately, that's an uncommon situation. One of these this week was a 15-year-old girl who fainted two years earlier during some athletic event, and the second faint was fatal. I can tell you that a colleague of mine a few years ago looked up the clinical studies in these patients. And the resting electrocardiogram is virtually always normal. The Holter monitor 24 hours is virtually always normal. The exercise stress test is virtually always normal. This is after a faint. So those tests are not very helpful. The only way to make the diagnosis is coronary angiography, really. Now, how does this work? Here's a situation of a right coronary artery coming off the left sinus, and the syncope or the fainting occurs during exercise, and presumably with exercise, the aorta and pulmonary trunk dilate, and it's likely that the reason problems occur is that the anomalous artery is occluded I think at the site of the origin by the dilatation of the 2 arteries. Fainting, in other words, is virtually never occurs at rest. Now this is a coronary artery anomaly. This is a single coronary artery. Rose from the right, went around to the crux of the heart, then continued as a left circumflex, then went on around and continued as a left anterior descending. It can be the other way also. Now this particular anomaly here occurred in a famous basketball player, Pete Maravich, that all of you know. As you know, Pete Maravich had had a scoring record per year in the NCAA of 44 points per game for each of 3 years. It's predicted that if they had the 3-point rule when Pete Maravich played, that he would have scored an average of something like 65 points a game. But Pete Maravich died suddenly at age 40, and this is what he had. His coronary arteries were devoid of atherosclerotic plaque. Actually, he had become a vegetarian, but he had a great deal of scarring in the anterior wall of his left ventricle, and the reason for that is as this artery came around, it gave off a very large left obtuse marginal here, and then the left circumflex continued around, and by the time it got to the site where the LAD is located, it was very, very small. This is a situation that is quite uncommon, but I think I've seen it now 4 or 5 times, and it is, no question, a cause of sudden death. And that is, whenever one has a dominant right coronary artery, usually the left circumflex is quite small. If one has a dominant left circumflex, usually the right is quite small. Occasionally one has a bilateral dominant artery, but on very rare occasion, one has hypoplasia of both right and left circumflex. And that's a very dangerous lesion for any of us to have. Now these coronary arteries which come off the wrong artery, obviously this is normal. When both right and left main coronary arteries arise from the pulmonary trunk, that's usually incompatible with life unless there's something like mitral stenosis present. Now the right coronary artery from the pulmonary trunk, usually this is a benign lesion. They reported a patient from Birmingham last year who died suddenly with this lesion. The left main from the pulmonary trunk, most of these persons have problems early in life. Usually by a year they're in heart failure and don't live much longer than that. One of the patients I saw at necropsy was a 44-year-old woman who died suddenly at her desk as a secretary, and this is what she had. She was a 44-year-old who slipped by that first-year period. And this is a tragic situation. We saw this a few years ago, the left anterior descending arising from the pulmonary trunk. This was in a soldier who had a systolic murmur, and he was worked up at Walter Reed Hospital, and then an angiogram, and they found out his LAD arose from the pulmonary trunk. And at another hospital, they went in to correct this, and what they did at the operation, they wanted to tie off this left anterior descending right as it came into the pulmonary trunk, but they misidentified it, and they tied off the left circumflex instead. And so that fellow miraculously survived operation, but while running, about 6 months later, he suddenly died. Now, there's some speculation periodically. There was a very prominent paper in circulation about 10 years ago saying that a tunneled coronary artery was dangerous and that it caused sudden death. Well, about nearly 25% of us have tunneling of a portion of the left anterior descending or a first diagonal or left obtuse coronary artery. Now, this is a situation which I've seen 3 times now. And this is the greatest example of tunneling I think anyone can have. Here was a situation where the left main coronary artery arose from the right sinus, and then the left main tunneled beneath the right ventricular outflow tract in the ventricular septum, and then appeared on the anterior wall of the heart, and then divided in left circumflex and left anterior descending. Now, we saw 2 cases just like this in a month's period of time, and both of them were men in their 30s who had been killed with a firearm. In other words, their hearts were otherwise perfectly normal, and yet the length of this tunnel left main, which is equivalent, of course, to 2 arteries, was 5 centimeters in length, and yet it never caused any trouble. I don't think tunneling ever causes anybody any trouble, and indeed the tunneled portion of the artery is almost always devoid of atherosclerotic plaque, whereas the epicardial portion obviously commonly is not. Now this is one of the most common coronary anomalies. That is a left circumflex either arising from a right coronary artery or directly from the right sinus. I'm sure you've seen this several times during coronary angiography. This is thought to be present in about 1 out of every 200 of us. If the left circumflex arises directly from the right, there are no reports, as far as I know, of that causing any symptoms during life. On the other hand, if the left circumflex arises directly from the sinus, from the wall of the aorta behind the sinus, then that angle is a very acute one. And then with exercise and so on, it could be blocked. I have seen sudden death in that occasion. Now to other causes of sudden death, myocardial causes. This is obviously idiopathic dilated cardiomyopathy, very dilated heart. And about 25% of these patients, as you know, do die suddenly. But that sudden death is preceded by congestive heart failure. I like to use a definition of sudden death, death outside the hospital. Now, I'm aware that that patient that you've just made ward rounds and doing all right, and you come back an hour later and that person is dead in bed, that person presumably did die suddenly. But if one intermixes death in the hospital, outside of the hospital, it gets quite confusing. It's confusing a bit to me to intermix sudden death in people with pre-existing heart failure compared to those not. Now, this is hypertrophic cardiomyopathy here. A typical, very small LV cavity, big atria, very thick septum, LV free wall. Sudden death is by far the most common mode of death in these individuals. Now, obviously, Dr. Braunwald initially, Dr. Epstein since then has studied a lot of patients at NIH with hypertrophic cardiomyopathy. This is the number we've studied, or the group we've studied at necropsy. They can be present at birth. We've seen it all the way up to the 9th decade of life. But irrespective of decade, no question, the most common mode of death is sudden. The other thing about hypertrophic cardiomyopathy, when you pick up that sports page in the morning and read that so-and-so, a football player or a basketball player, died suddenly during an athletic event, the most common disease underlying that sudden death is hypertrophic cardiomyopathy. Now, this is some data that Dr. Barry Marin and I collected a few years ago. We did read the sports pages every day to try to identify these patients and would call around the country. As I think about that, I could have deducted the newspaper from my income taxes. I forgot about that now. But the point is that hypertrophic cardiomyopathy, among this group we studied, and these were competitive athletes. These were not just runners. These were competitive athletes. Several were professional athletes at this age group. Hypertrophic cardiomyopathy, most common. This group, idiopathic left ventricular hypertrophy, this may well have been hypertrophic cardiomyopathy. Atherosclerotic coronary artery disease was present in a few of these patients despite the young age. Coronary anomalies, hypoplastic arteries, sarcoidosis. You had one of these patients here in Atlanta as a member of the your National Basketball Association team. And this is it. This is what? Sarcoidosis. And this was an athlete right here, and he died suddenly during an athletic event. And this is sarcoid granuloma just invading his myocardium. So even sarcoid can cause sudden death. It seems to me, at least in my experience, sarcoidosis either goes down the non-heart road, that is presenting with lung problems or eye problems or so on, or it goes down the heart road. And if you look for patients with cardiac sarcoid in the pulmonary clinic or the eye clinic, you're not going to find them. You're going to find them in a heart clinic. And they often, of course, have these arrhythmias, primarily ventricular arrhythmias. The 25-year-old who presents with complete heart block, you've got to think of cardiac sarcoidosis. Same with complete bundle branch block, etc. Now, this is myocarditis, and I don't see much myocarditis. I realize it's talked about a lot. The most common cause of myocarditis in my experience by far is infective endocarditis involving a valve with spread to myocardium. The next is the cancer patient who develops a widespread infection. But to see inflammation in myocardium unassociated with ischemia, every myocardial infarction really is myocarditis because there's pus in the heart in acute myocardial infarction. But this is a case of a lawyer about 30 years of age who was perfectly healthy, and all of a sudden he went into heart failure, and in 30 days this picture was taken. His heart was just loaded with mononuclear cells, and we never determined why. Now, sudden death from valve disease. I realize that aortic stenosis is said to cause sudden death. It's very uncommon to see that today because most of these patients get operated on. I have seen a patient with aortic stenosis who died suddenly. This was a man who had severe aortic stenosis, and he was walking behind a horse one day, and the horse kicked him in the head, and he died. And that was very sudden, and he had aortic stenosis. But in general, sudden death is very uncommon in my experience from aortic stenosis. Now, this is a situation that may cause sudden death. This is the heart of a man. He had two valves in, but oops, you see the poppet here, and the poppet's gone there. Now, this man was standing up in church singing, and all of a sudden he collapsed, and the poppet came out, and boom, it went down the aorta. This was a man heart of a man who was walking across the street in Washington, D.C., and suddenly collapsed. As far as anyone knew, he'd always been healthy. And lo and behold, at necropsy, this is pulmonary vein here, and saw cancer of the lung growing into the pulmonary vein, filling the left atrium, and really obstructing the mitral valve orifice. So if one is dealing with sudden death, you cannot assume that the cause is atherosclerotic coronary disease, irrespective of the patient's age, until you do a necropsy, because there are many, many surprising causes. Now I say we, a young man with me, Dr. Alan Dollar, has been looking at the group of cases of mitral valve prolapse we've seen through the years. And about 15 of the patients with mitral valve prolapse we've seen, which is about probably about 60 now, died suddenly. And the thing that was interesting, at least to me, was that only 1 out of the 15 had pre-existing mitral regurgitation. There have been some reports that patients with mitral valve prolapse who die suddenly have a good bit of pre-existing mitral regurgitation. That's not the case in the group that we've studied. Now, a couple of the patients just had systolic clicks during life. Most had a systolic click plus a mid-late systolic murmur. Those who go on to develop pansystolic murmur, wide open mitral regurgitation, that in my experience is not a type patient to die suddenly. Now, this was a young lady with mitral valve prolapse. It looks like hemorrhoids of the mitral valve. And this was a man. This man died suddenly. This fellow was 46 years of age. This is mitral valve. You see this huge prolapse here. And this is a tricuspid valve with prolapse there. This fellow had a click, a late systolic murmur. He had an echo typical. He even had a left ventricular angiogram. He was at a dance one night, just finished doing a jitterbug, sat down, collapsed. That was it. Now, we've not seen any myocardial lesions in these patients, no abnormalities of the coronary arteries. Why some of these patients die suddenly, I don't know. Now, what is that? This is the right coronary artery. This is the left main coronary artery. That's the left anterior descending, left circumflex. That's the innominate artery here. And here we have a huge aneurysm involving the sinus portion of aorta and the proximal tubular portion of aorta. Now, the reason that picture was taken was because that aorta split right there. Now, this was the heart of a young man, a trumpet player. And he had been playing the trumpet in a band one night. And he drove his car into the garage, and he never got out. And his mother went out to the car after a while and found him collapsed. And what he had, well, he had ruptured this wall of this aneurysm, and he had typical Marfan syndrome, and he had hemopericardium here. Now, these aortas that get very dilated from the Marfan syndrome tend to rupture, and these are the splits that they get. They may be transverse, longitudinal, and this is the fatal one. It's right on the right lateral wall there where the blood is ejected from the left ventricle. Now, this is a typical aorta of a patient with Marfan's, and this is a normal aorta. Now, this aorta, the black, represents elastic fibers. And in the Marfan aorta, you hardly can see these elastic fibers. In this particular patient, there are just a few left. So there's massive degeneration of elastic fibers, and the integrity of that wall is gone, so it dilates. Now, this is an aorta. This is aorta here, and this is an aneurysm of a sinus which protrudes not into the right ventricle, but outside into the pericardial sac. This was a young woman, 33. She was cleaning a house one day and suddenly collapsed. Necropsy was done. The pericardial sac was filled with blood, and lo and behold, she has this aneurysm of the sinus of Valsalva that protrudes not toward the right ventricle, but outside, and there's a little rupture site right there. Now, had a necropsy not been done, we'd have never known why she died. Now, dissection of an aorta, obviously this kills early. It usually does not kill within an hour, but occasionally it does. So dissection has to be plugged into the sudden death group. We've seen all kind of aneurysms of ascending aorta, descending thoracic aorta. The bigger the aneurysm, of course, the greater the chance for it to rupture. Now, since President Kennedy was killed in 1963, we have accumulated, I believe I read the other day, about 45 million more pistols than were present in this country at the time of Kennedy's death. Now, in Washington, D.C., where I live, this is the murder capital of the entire planet. And unfortunately, we see gunshot wounds to the heart, and obviously that's a major cause of sudden death. We've seen knife wounds to the heart, almost perfectly placed ones at times. Automobile accidents, of course, can rip aortas, rip hearts. This has to be plugged in. And finally, just to summarize, I think when any of us talk about or read about or discuss sudden death, we can't simply assume that we're talking about coronary atherosclerotic disease unless these other multiple causes are ruled out. Thank you very much for your attention.
Thank you, Bill. That was spectacular as usual. There are probably not but about 3,000 important clinical pearls in there, and so you couldn't even begin to touch them. I wanted to ask you, I heard someone define sudden death. What's the difference in a faint and sudden death and the one you wake up from? And if you have, to fix on one point, if you had a child or someone brought you a child or a young person who had quote-unquote fainted during an athletic event, what would be your recommendations?
Well, that's a tough problem. I'll tell you, about 2 years ago, a child who was 12 at the time did exactly what you said, was playing soccer, fainted. The mother, he woke up. The next day, the mother took him to their pediatrician, and the pediatrician said, "Oh my goodness, must have a coronary anomaly." So he did a electrocardiogram, did a 24-hour Holter monitor, did an exercise stress test. Everything was negative. And now, should he do a coronary angiogram? First faint, obviously fainting is relatively common. And so he discussed this with the mother and said, well, if your child faints a second time, we're going to have to do a coronary angiogram. And sure enough, the second faint came 2 years later, and it was fatal. Now, that doctor is being sued. It's a very tough problem. I don't know the answer. I do know that the electrocardiogram, the exercise stress tests, and the Holter are not going to help you decide. Now, maybe the echo is getting better in picking out coronary anomalies. Maybe that'll be the way to go before an angiogram, but it is a tough problem. And if one does find a left main arising from a right sinus, you've got to operate right away. You should operate, in my view. And doing a bypass on somebody with perfectly normal coronary arteries is not the easiest procedure in the world. So that's a risk too. So it's not an easy decision either way, it seems to me. But it's not a malpractice case, I know that.
Let me ask you one related question, of which we've had some discussion and some disagreement with on our staff here about young people who are asymptomatic, who are found by serendipity or otherwise to have hypertrophic disease, non-obstructive disease, but hypertrophic disease. Would you preclude competitive athletic activity?
I think that's who you talk to. I can tell you that Dr. Stephen Epstein at NIH and Barry Marin, they recommend non-competition for the patients with hypertrophic cardiomyopathy. If I was a real doctor, I don't think I would be so adamant, particularly if there was no evidence of a gradient, because we've seen this condition in the 90s now. It turns out that the typical hypertrophic cardiomyopathy patient is like the typical patient with a bicuspid aortic valve, very vigorous, healthy, strong, natural athlete type. I think one has to be flexible there. I think it's not like the 20-year-old with a 90 millimeter gradient across a stenotic aortic valve. It's very different from that. That's my view.
Okay, thank you. Are there other questions? Dr. Treasurer.
Dr. Roberts, you answered part of my question, I think, but we recently had a case in the cath lab here, and a lady whom we incidentally found an anomalous origin of the left main from the right cusp. She had an insignificant VSD, and that was why she was cath. And in trying to decide how to manage her, I gather you would do nothing to work her up and go ahead to bypass. Could you comment on the chances of those bypass grafts staying open in the long term, and how would you manage her down the road?
Well, there have actually been very few of those patients, to my knowledge, who've actually gone on to bypass. So what's going to happen to those conduits placed in perfectly normal coronary arteries, I don't know, but obviously in some of the congenital young people, the coronary arteries have been moved around. I don't know. I think that's a very dangerous lesion. I think you really put yourself up for potential trouble if you sit on that patient.
Do those coronaries just anatomically lend themselves to reimplantation?
My view would be, I don't think so. Now, Denton Cooley might have another view about that. They're way down. They're right in the heart, right behind the pulmonary trunk. It's very difficult to get to. It's not like a normal location.
Any other questions? Well, if not, let me ask one final one. In your patients who have coronary disease and no evidence of infarction, no evidence of clot, who presumably are not in an active state of their disease, what are they dying of?
Well, I don't know the answer to that, but That's why I brought up that stress situation. I think that who's the man in Boston? Yeah, Bernie Lown. I think he was getting at something good. And this fellow whose slide that I showed here, I think that superimposed stressful event in somebody who has very narrowed coronary arteries, it doesn't take much to tip the scales. I mean, as a psychiatrist say, we all walk that fine line between insanity and otherwise. I think with myocardial ischemia, we're all walking the fine line between adequate oxygenation and inadequate. And it doesn't take much to tip it over. And I don't think it necessarily has to be a new anatomic event in the coronary artery.